So next is pyloric stenosis, V36. 6-week-old male is brought to A&E with 1 week history of projectile vomiting. Projectile vomiting. If asked to see him, how would you manage him? So I would take a history. Was the child feeding normally up to now? Is the vomit milky or bilious? Is he hungry after feed? Weight loss, family history of similar problems. I would perform an examination like dehydration, abdominal distension, palpable lump in the right upper quadrant. He has lost 10% of body weight, is always hungry, and you think you can feel a mass in the right upper quadrant. His father had a similar problem when he was a baby. What is the differential diagnosis? Given the classical history of non-bilious vomiting, positive family history and examination finding, the most likely diagnosis is hypertrophic stenosis. Hypertrophic pyloric stenosis. Other difficulties include the infective causes like gastroenteritis, pneumonia, UTI to meningitis. Gastroenteritis reflects overfeeding, congenital adrenal hyperplasia, pylorospasm, and raised intracranial pressure. What is epidemiology of the pyloric stenosis? Incidence is 1 for per 1,000 birds, more common in the firstborn. A positive family history is a significant risk factor. And how will you confirm the diagnosis? Clinically, this can be done 80% by the cases by palpating the pyloric mass. Ultrasound is the gold standard. Muscle thickness is greater than 4 millimeter and length is more than 16 millimeter. There is obstruction in the progress of gastric fluid across the pylorus. How will you manage the condition? Firstly, resuscitate the baby and correct the electrolyte imbalance like hypokalemic metabolic alkalosis due to vomiting with renal compensation. So in vomiting, baby is losing iron. That's why it's alkalosis. So gastric contents also has chlorine and potassium. So if not corrected, then patient can proceed to paradoxical aciduria. So paradox means opposite. To conserve the hydrogen ions in the presence of alkalosis, sodium potassium hydrogen exchange pump works in favor of losing more potassium, further aggravating hypokalemia. However, when hypokalemia is extreme, this is a compensation. Hydrogen ions are preserved and potassium is excreted. But when hypokalemia is extreme, sodium potassium hydrogen pump attempts to conserve the potassium at the expense of hydrogen ion, hence paradoxical aciduria. I would refer the baby to my pediatric surgical colleagues to have a Ramsted pyloromyotomy. This can be performed either in upper and laparoscopic, incise longitudinal along with the interior vascular of the pylorus, olive sparing the mucosa, split the hypertrophic muscle with a spreader down to the intact mucosa. So risks: inadequate, incomplete pyloromyotomy or perforation.